next invite Dr. Varshini, who would be talking about now another very important investigation in neuro-ophthalmology, OCT, and what role does it play in our day-to-day practice.
Good afternoon, everybody. Thank you so much for inviting me to be a part of this talk. So I'm going to be presenting about OCT and is it essential for neuro-ophthalmologists. So looking at the type of OCTs which we get, these are the 4 different machines, 4 different printouts which we are reasonably familiar with. However, they differ in scanning protocols and segmentation algorithms, and the measurements are not comparable between one and the other. What do we actually look at when we look at an OCT? We look at an optic nerve head analysis, we look at a peripapillary RNFL analysis, we look at a macular ganglion cell analysis, and again this is what differs from machine to machine. When we look at this segmented OCT of the macula, the 3 layers which we are interested in is the ganglion cell, its axons and its dendrites, and the various the Cirrus HD OCT gives us, as a GC-IPL, it gives us a combination of ganglion cell layer plus IPL layer, whereas the OptoView machine gives us the thickness of the RNFL, the ganglion cell, and the IPL. And for this reason, we cannot compare between the machines. This is the printout which we are used to seeing, and we can get a lot of information from this, mainly about the retinal, about the RNFL layer. If we look at, we also look at, always need to look at the ganglion cell analysis in combination. And at this point, I'd like to point out that there are 2 different scales which are working over here. So when you look at the RNFL thickness and the ganglion cell thickness, yellow and red are thick, which is what gives the RNFL thickness the characteristic butterfly shape, and the ganglion cell layer the characteristic golden donut shape. And when we are looking at the RNFL quadrant-wise and the ganglion cell sectors, then red is thinning and green is normal. So coming to the most common conditions which we see in a neuro-ophthalmology OPD, optic disc edema. Optic disc edema occurs when the intracranial pressure is transmitted to the subarachnoid space, flattening the posterior sclera, causing an axoplasmic stasis and pushing the optic nerve forward. This can be visualized on an optic nerve, on an OCT as RNFL thickening, as we see in the right eye. We can also visualize the other signs, which is the absence of the optic cup, the increase in volume of the optic disc as well. And retinal nerve fiber, retinal folds can be visualized as peripapillary wrinkling, which is a very specific sign to differentiate between optic disc edema and pseudoedema, maybe due to optic disc drusen. This OCT is extremely helpful to differentiate mild optic disc edema from pseudoedema, but what happens when you have repeated optic neuropathies and optic nerve thinning? Then we get something called a floor effect, which means that there is so much structural damage that further thinning or thickening can no longer be appreciated. So in cases like those, for example, in a patient who's had multiple attacks of IAH with subsequent optic atrophy, then also the OCT is quite helpful. In which case, we look at the Brooks membrane, the shape of the Brooks membrane in, along with the reference plane. So in a normal patient, or when the ICT is normal, the Brooks membrane would have a flat appearance or a V-shaped appearance. When the, as in the second picture, when the pressure increases, then this Brooks membrane is pushed forward towards the vitreous, forming an anterior deformation or a D shape. Once this pressure is relieved, once again the Brooks membrane comes back to its normal position. The second most common condition which we encounter in the OPD is optic disc drusen. Now that we know that drusen is not merely incidental finding or a benign pathology, and frequently with the years it leads to progressive, becomes more superficial with RNFL thinning, ganglion cell loss, and progressive visual field loss as well. So we do want to detect drusen as early as possible for prognostication. So fortunately for us, the Optic Disc Drusen Studies Consortium has given us these guidelines on identifying drusen on OCT. So optic disc drusen are always located above the lamina cribrosa. They have a signal-poor core with a hyperreflective margin, which is usually seen superiorly. They may be seen as conglomerates of smaller ODD with internal reflectivity. Hyperreflective horizontal lines might represent early ODD but are not actual drusen. And peripapillary hyperreflective ovoid mass-like structures, which may be present in other forms of edema as well, should not be identified as drusen. We can currently say that EDI OCT may now be the gold standard instead of B-scan ultrasound because it offers us several advantages. It helps us in quantifying drusen size, has a higher detection rate, correlates with the visual field defect, and monitors progression as well as measuring progressive RNFL and ganglion cell loss. Coming to the next condition in optic neuritis, this is a patient who presented with bilateral optic neuritis, enhancement of both the optic nerves, the chiasm and the right optic tract. With treatment, the vision normalized as well as the visual field. However, when you look at the OCT, comparing the initial to the final, we can see that the RNFL, there is mild RNFL thinning, but significant ganglion cell loss, which is visualized even better when you do a progression analysis. So extremely helpful in these cases. It also helps to identify the amount of RNFL loss, also may help to identify associated conditions. For example, optic neuritis associated with NMO has much more significant RNFL loss compared to optic neuritis associated with MS or single episodes of MOG associated optic neuropathies. This is a patient with an optic nerve sheath meningioma. You can see the disc edema in the right eye, and you can also see the RNFL thickening associated with the ganglion cell thinning, which can be used to monitor progression and further loss. In toxic optic neuropathies as well, you can see a thickening of the RNFL along with thinning of the ganglion cell layer, which may be one of the early signs to indicate toxicity. In chiasmal lesions, you have compression of the binasal fibers, which shows up as bitemporal hemianopia, but can also be seen as binasal thinning on the ganglion cell analysis. Retrochiasmal lesions, which were initially thought not to cause too many OCT changes, now we can see that the pattern is reflected on the ganglion cell layer. So if you have a left homonymous hemianopia, for example in the right eye, if you have a nasal field loss, then you will have a temporal ganglion cell loss, and similarly in the left eye, if you have a temporal loss, you will have a nasal field loss. Nasal ganglion cell loss. And I will wind up by just adding a comment on OCT-As. There are some conditions where OCT-A is also extremely helpful in neuro-ophthalmology. This is a patient with chronic IAH whose vision was not improving beyond 6/9, but when you do an OCT-A, you see that there is a front of new vessels due to a peripapillary CNVM, so it's extremely helpful in identifying these conditions as well. I would like to sum up by saying OCT has revolutionized management of neuro-ophthalmic and neurologic conditions in diagnosis, disease monitoring, as well as prognostication. Thank you.
Thank you, Dr. Varshini.